Good evening, one and all. I would like to welcome you all for this IAOHNS GSK Webinar Series on Contemporary ENT Practice Webinar Series, which is planned with an intention to update on common clinical conditions prevailing among ourselves with a galaxy of eminent faculty. So this month, we have chosen a topic which is very commonly seen in our OPD, and most of the times we may unnotice it and it may go unnoticed. That is the association between allergic rhinitis and obstructive sleep apnea. So I would like to request our President-elect, Dr. Gautam Khan, to introduce the moderator, Dr. Srinivas Kishore. Over to you, sir.
Thank you, Dr. Vijay. Good evening, everyone, and on behalf of the Indian Academy of Otolaryngology, Head and Neck Surgery, IAOHNS, I welcome all of you to this webinar on contemporary ENT practice. And today's webinar, as Dr. Vijay has mentioned, is on sleep apnea and allergic rhinitis. We have got an eminent speaker, Dr. Jimenen, will be speaking to us, and Dr. Srinivas Kishore, who is the moderator for this session. Dr. Srinivas Kishore is well known in the ENT circle in India. He is at present the director of the AIG of ENT at the AIG Hospital, Hyderabad. He has been a very well qualified person. He has done fellowships in endoscopic sinus surgery from the University of Pennsylvania in 2004 and 2005. He has done fellowship in sleep apnea surgery in Singapore, and also from the University of Wisconsin. His main interest is in snoring and sleep apnea management. He has many publications in various international and national journals. A very affable person and a very efficient surgeon, as well as a very good speaker. I welcome you, sir, to carry the process forward. Thank you very much.
At the outset, thank you very much, Dr. Gautam, for those kind words. Thank you very much, Indian Academy of Otolaryngology and Head and Neck Surgery, for a wonderful platform and selecting such a fantastic topic. And to take us through the journey of this particular topic, and I would like to use the French word crème de la crème of sleep, at least in this part of the world. To start the proceedings, I would invite Dr. Jimenen Jahindran, who's a good friend of mine. His thoughts and his approaches are very revolutionary, and you would see that during his talk. And before I let him speak, I would like to give a small introduction of who Dr. Jimenen is. So he's a graduate of Manipal. He's a private ENT surgeon based in Pantai Hospital in Kuala Lumpur in Malaysia. His keen interest is in rhinology and sleep-related breathing disorder, and is recently diving into new areas of functional airway disorders. He's of course presented in both local, regional, and international meetings, and promotes the idea of integration in airway management. And he's the go-to person for airway-focused dentists in Malaysia. And with that short introduction, Dr. Jimenen, can you please start your presentation, please?
Thank you, Srinivas, for those kind words. Too much actually, but anyway, thanks. It's a pleasure to always come back and give a talk to my colleagues in India. And always, since 2017, I've always seemed to be bringing new ideas and new thoughts to this platform. So allergic rhinitis, as we all know, is such a common disorder, but it seems to be that we always neglect this disease, and we seem to not look at it in a very holistic way. So let me put across this idea, and let me see if I can change your thoughts on this. I'll start sharing my screen now. Can you guys see this?
Yes.
Okay. So I'm going to just sort of tie up what is actually going on between allergic rhinitis and sleep-disordered breathing. And it's strictly for healthcare professionals, and a lot of the content is actually my own opinions and do not reflect the opinions or position of any company. I do get honorary giving lectures for these companies. So to start off with, I think the first thing that we have to look at is we need to look at atopy as a systemic disease. That means it is not something that it's going to be different in different compartments or different areas of the body. We need to look at a primary disease that is affecting multiple systems which have been named differently and have been looked after by different specialities. So we all know about the allergic march. I shall not delve into the details of this. But what we really want to understand is the concept of minimal persistent inflammation. So the onset of atopy can be as early as infancy with colic and atopic dermatitis. And if you look at the recent literature in atopic dermatitis, they are moving away from looking at it as a skin disease, but as a systemic disease that triggers an inflammatory response, not just on the Th1, Th2 pathway, but on an inflammation based on the whole body. So what is actually going on is, and even this I've actually told Srinivas before, even when you look at a child with atopic dermatitis, and if you look into their nose, although they have no symptoms, the appearance of the turbinates do look as if they have got some rhinitis. They have that moist looking appearance, which is not a normal looking turbinates. So I believe that in this whole area, the concept of minimal persistent inflammation is what is driving the disease. And you only see symptoms when a certain particular threshold level is reached. So that's why with allergic rhinitis, you see symptoms in the morning and you see nasal congestion at night. But the rest of the day, when there's no symptoms, it doesn't mean that there is no disease. So we need to shift our attention from treating symptoms and to move towards treating disease. We know that the allergic landscape is changing, and this is because pollution is going up, higher risk of sensitization and airway responsiveness. We are facing more indoor environment and lifestyle changes that are bringing about atopic changes. We are getting exposed to new allergens, and a psychologically stressful lifestyle is definitely contributing to the risk of sensitization. So we are seeing more severe symptoms, we are seeing more persistent symptoms. So what are the risk factors for atopic disease? Well, we all know familial background and genetics play a role. But I think now, if you look at it, epigenetics seems to be playing a huge role in the expression of these genetic influences. And these are coming from environmental and lifestyle and developmental factors. Then there's concept of allergic sensitization. Now, we are also looking at literature to see if delivery process has got a role in contributing to the risk of developing atopy. And it seems to be that cesarean sections and instrumental deliveries may have a role in this. Paracetamol used during pregnancy, tobacco smoke without a doubt, respiratory viral infections, obesity, occupational exposures, air pollutions, dietary factors, and I also will be focusing on breastfeeding, how it actually influences this. So I love this diagram because this basically simplifies everything. So if you look at allergic rhinitis and if you just look at the symptoms, what you're going to see is going to be a very symptomatic approach. But what you don't see is what's going to cause the problems, and this does not mean that if you don't see it, you don't treat it. Now I'm going to shift the whole talk towards the whole concept of physiology of respiration. See, the whole problem is in this area, we are using terms very loosely without proper definitions. So if you look at the concept of respiration, and especially in sleep circles nowadays, we talk about nasal breathing, we talk about mouth breathing. But if you go back to the simple basic concept of respiration, we learned in medical school that the primary muscle of respiration is the diaphragm. So I think we have to shift now and talk about diaphragmatic breathing. So where does the nose and the mouth come into the picture? Now, if you look at this picture, you can see that based on diaphragmatic movement and chest wall movement, you're basically creating a pressure differential that now is going to bring air through the nose into the lungs. But to maintain that whole sealed tube, the oral cavity is going to have to play a very important role. And this is where lip seal and tongue posture comes into the place. Now, tongue posture is now becoming more and more important because we seem to be understanding that physiologically the tongue has got a lot of connections and it's got a very important role. So you need to get your tongue to sit in your palate, and that palate has to be on an adequate sized palate. So these three components of patent nasal cavity, good lip seal and correct tongue posture will be very dependent on the dimensions of the skeletal box or the skull. And this position of the maxilla and the mandible will also dictate how a person's posture is going to develop. So all these things are going to happen very early in life. And if we do not watch out for all these symptoms when the patient has not even developed allergic rhinitis, we should be more aware of when kids are developing atopic dermatitis, when they're having their frequent upper respiratory tract infections, when they're having their tonsils and their adenoids. This is where we need to pick them up early. So the moment you have an open mouth posture and a tongue that is sitting down, you completely break the whole respiratory seal, as I would like to refer it to. So the whole respiration is actually the whole process of respiration is actually multiple circuits. And all it takes is, if you take one component of the circuit out of the picture, the whole system collapses. So this is something that we need to understand. How you breathe determines how the face grows and your body functions. And Melvin Moore spoke very beautifully about it, that form follows function. So if you look at the skull, it looks like the development of the nose and the sinuses may be dependent on how well we breathe through our nose. The orbit, how the orbit develops may be dependent on how the eyeball grows into the orbit, how the brain grows into the cranium, how the tongue grows to allow the palate to move forward and laterally. These are concepts that are there, it has already been written about, but we have just not looked into it. The domino effect of not managing rhinitis is nasal obstruction and consequent mouth breathing. Now, my friend Yap Srinivas knows him very well. He drew up this diagram very beautifully, and he looked at mouth breathing as the core of the issue. Again, I'm using this word mouth breathing in the sense that where the whole sequence of physiological breathing is taken apart because the nose is blocked. So allergic rhinitis will contribute to mouth breathing. We used to think that adenotonsillar hypertrophy was causing mouth breathing, but it may be vice versa. It's mouth breathing that causes adenotonsillar hypertrophy. Tongue ties, without a doubt, may influence mouth breathing. There are tone issues in the tongue, and there are tongue restriction, mobility of the tongue restriction, movement of the tongue restriction may also cause this. We know that mouth breathing is an independent risk factor for asthma. There are cognitive issues and behavioral issues involved in children. Mouth breathing will definitely have an impact on craniofacial development, nasal development, and also your posture. And when this whole system goes haywire in childhood, you're basically putting all the steps in place for the last stage of a dysfunctional breathing spectrum, which is obstructive sleep apnea. So we need to look at obstructive sleep apnea as a preventive disease. So where do we pick this up? We need to pick it up in childhood. So we need to understand the whole concept of craniofacial morphology. So when you bring atopy into the picture, it's really a very complex interplay between etiopathogenesis and growth effects on the craniofacial complex. It's a real chicken and egg story. We don't know which comes first. Atopy causing growth issues or growth issues causing atopy. So this is something we need to look at. But we do know that this leads to mouth breathing and it further aggravates the condition, and it seems to be the predominant factor in all aspects of breathing disorders. So when we look at the whole treatment paradigm, we need to now look at treatment in how to re-establish nasal breathing, how to get that lip to seal, how to get the tongue to sit in the correct position, and how to correct your general posture itself. So it should entail a very holistic approach. The younger you look at these patients, it's easier because you're going to use growth modification strategies, and structural or surgical correction should be in the context of restoring physiology. And we should be able to put everything in place so that the body learns how to sustain this naturally. Because if you realize that respiration is actually an automatic process, we don't breathe consciously most of the time. So we need to put the system in place so that it all occurs nicely. So looking at the craniofacial morphology is like looking at a double-story house. So we need to understand that when we look at the skull, whatever changes that is going to occur in the nose is going to be a direct relation of what is going to be happening in the maxilla, in the mandible, or vice versa. So we need to now understand, looking beyond ENT may be an answer. And it's not beyond ENT. The oral cavity is still part and parcel of our game. But all we need to now understand is we need to look at the skeletal component as well. So nasal obstruction is one of the most, what is the word I would like to use, is one of the most, it's actually a disillusionment. It's not a good symptom for us to understand because our patients have got no clue about nasal obstruction. And when we ask our patients, we ourselves have got no clue what nasal obstruction is. See, when we understand nose block, when we have a flu or an upper respiratory tract infection, we cannot perceive our breathing through our nose and we consider it nose block. But if you look at the skull on the left and if you look on the skull on the right, both these patients are going to be breathing normally. But now if you look at it in a very different aspect, you know that breathing through the left skull is like breathing through a 4-lane highway, whereas breathing through the right is through a 2-lane road. Now, if you have a skull like this, what is the patient going to do? The patient is going to compromise by opening his mouth, the tongue will fall down and move behind, and the jaw is going to become narrower. So we have to completely change our idea on how we look at nasal obstruction. We need to ask different questions, not nose block. Are you waking up with your mouth feeling dry? Do you drink water in the first thing when you wake up? So, and then one of the things that actually tells us is you have to look at the posture, because we now have to have a different outlook in all this. So if you look at the palate now, you will understand that transverse diameter of the palate is very, very important, and especially in the region of the premaxilla, which would directly relate to the internal nasal valve in the nose. So this is actually an evolutionary change which we have seen in the last 400 to 500 years. And this is influenced by a lot of epigenetic influences. So we are seeing now a very narrow transverse diameter. And if we are not looking at this properly, and if we do any sort of orthodontic work without respecting the space for the tongue, we may actually create an airway issue further down the line. So this is an area which is still very controversial, but I'll talk about it later. So we have seen how progression evolutionarily from similar skull bases which have remained the same. From massive muscles, we have gone to smaller muscles. From massive alveolar bone, we have gone to smaller alveolar bone. From straight teeth, we have gone to crowded teeth. From functioning third molars, we have got to impacted third molars. Now, if you look at the human as a species, and if you look at teeth, there is no other animal in the human world, in the world, that you will see crowded or crooked teeth other than humans. So we need to ask ourselves why. So I've talked about breastfeeding. Now, the concept of breastfeeding and how it actually is going to influence sleep disordered breathing. Breastfeeding, the act of breastfeeding actually trains lip seal by latching, and it trains to push the tongue against the palate to allow normal transverse maxillary development. When you get normal transverse maxillary development, you will get a normal nasal airflow. But when you have reduced transverse maxillary development, you start mouth breathing, and you're going to see all these other diseases that we see routinely in ENT. Otitis media with effusion, adenoids, tonsils, frequent sore throats, and even atopic diseases. And we have shown now, even in adults who are bottle fed for long periods of time, you will see this reduced transverse maxillary development, reduced oral space, a tongue that is actually sitting downwards and it's pushed backwards. So we need to open our ideas to all these things. I'm going to
Mouth
just run this
breathing
short
allows the
video.
air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore,
I know Srinivas and me, when we discuss this, we call this the dog snout appearance, and which is very common if you see it in a lot of our kids. So this literature in this is not new. We've seen articles even a lot longer than even in 2008, 2009, and they have shown the adverse effects of growth, health, academics, and behavior. Now you can see how the facial profile changes in this child with allergic rhinitis. So just to digress a little bit, I'm just going to tell you, these are the symptoms of nasal obstruction in children. They're mouth breathers, they may have a little bit of rhinorrhea, otitis media, eustachian tube dysfunction, orthodontic problems, grinding. Now, we have to understand now that grinding is now looked at as sleep movement disorder, bedwetting, forward head posture, restless sleep. I call them the helicopter kids. They move all around the bed during the whole night. They're small in size. They've got poor sports performance, behavioral problems, learning disabilities, frequent awakenings, and snoring. So even if you look at the whole, the thing in children, you can see that sleep disordered children, a majority of our cases are actually non-obese. And they present with hyperactivity, failure to thrive, underweight. And trust me, even if their tonsils and adenoids are big, but just removing them may not be the only solution. These are all literature which I'm going to go through very fast over the next few minutes. Peter Catalano and John Walker wrote this, and they said that about 70% of our behavioral problem children actually are just, they're not nasally breathing. Talking a little bit about posture, if you mouth breathe, you can see how the craniofacial development is going to push you into a very dodecacephalic appearance of the skull. And because when you have a dodecacephalic appearance, you will develop a forward head posture. Now, we also know that when you have a forward head posture, for every 1 inch your neck moves forward, you're going to put 10 to 12 extra pounds on your shoulder. And to counter this, your pelvis is going to tilt. So now you're looking at, even with patients who are mouth breathing, whether scoliosis is, you see scoliosis in these kids, and they're about 5 to 10 degrees off. So, and this will affect how they grow on a very unbalanced system. This is a study that shows how the cervical muscle recruitment during nasal inspiration, before and after respiration, and postural exercises. So they have actually shown how breathing through the nose and breathing through the mouth actually shows muscle changes in your neck. And here we have also shown now studies of atopy among mouth-breathing pediatric patients referred to a tertiary care center. They have shown that a high positive prevalence of allergic tests highlights the importance of investigating these mouth breathers. Now they're looking at studies on mouth breathing on atopic dermatitis. So like I told you, there's a chicken and egg story. We don't know which comes first. But once they have, we know that the more earlier the onset of atopic dermatitis, the more severe the atopic dermatitis, the higher the risk of respiratory disorders. So we need to start looking at these very, very early. Again, some literature on atopic dermatitis and mouth breathers. And this was a very interesting study that showed that mouth breathing alone may increase asthma morbidity by about 18%. And this was finding from a study that showed that adenotonsillar hypertrophy in mouth breathers, they were found that there was no direct correlation between tonsil size and atopy, suggesting that other possible factors are also important in causing chronic inflammation in non-atopic population. And this is what they were referring to as the skeletal changes. So we need to understand that airway and breathing is actually a very complex puzzle. There are genetic influences, there are epigenetic influences, there are influences on early feeding habits, lip seal, tongue posture, tongue ties, atopic diseases, mouth breathing, posture, maternal stress and delivery processes, how the cranial nerves and reflexes integrate themselves, and how the retained oral reflexes can actually worsen all these things, causing hypotonia, and how breathing is actually very, very intimately related with also proper swallowing. This is a very interesting thing that I would recommend all of you all to read, because it's about the jaw epidemic, and this is a very interesting paper that was written. I got to know about this from a dentist in Australia called Simon Wong, and it basically shows the differences from how we have evolutionary role has played over the last few hundred years. So now I refer to this as the holy trinity of airway, the troika of posture, occlusion, and airway. So we know that these three things really have to go hand in hand. And if any of this is one component is out, all three are going to go out. But we have shown now that this actually leads to increase in blood pressure, increase in heart rate, and increase in cortisol hormone levels. And when you restore the holy trinity, everything goes back to normal. So now I'm going to tell you, come to the nose. We know it's not just for aesthetics, and it's a natural pathway for breathing. Again, the nose is a very important conduit. We need to breathe through the nose 96% of the time. Nasal physiology is very dependent on the physical structure of the nose and individual components within the nasal cavity. That means how the inferior turbinate is, how the middle meatus is placed. Everything may have an overall effect on the aerodynamics of the airflow. And does breathing change with age? We need to also understand the role of muscle tone and strength and how this breathing will get worse over time and our ability to compensate will become lesser. So, sorry, I'm just going to run this very quickly just to show you that there is a very definitive airflow through the nose. That means the air, the way it flows through the nose is very specific. It goes over the inferior turbinate into the middle meatus and out into the posterior choana. We need to respect this dynamics in the nose. So when the palate position is changed, you can also understand that the piriform is also going to get narrower. And when a piriform gets narrower, that's why you see in most of our allergic, now this is purely observational, you will also see that the middle turbinate is always tends to be a little bit more lateralized in our airway patients. So if you look at some literature, they even say there are about 30 functions in the nose, but I'm only going to concentrate on 6. So other than breathing and smell, filtration, humidification, moisturizer, and this whole concept of nasal nitric oxide. It's a very important inflammatory mediator for allergic rhinitis, CRS, and asthma. It's a very potent antibacterial and antiviral. It enhances pulmonary oxygen uptake via local vasodilation, and it behaves like an aerocrine hormone which increases arterial oxygen tension and reduces pulmonary vascular resistance. Now, if you look at some of the nitric oxide papers, you will know that the maxillary sinus is the biggest reservoir of nitric oxide. But we have also shown to have nitric oxide in the anterior end of the inferior turbinate, which actually plays a role in the inflammatory mediation of allergic rhinitis. So I think we need to now look at the concept that when air flows into the nose, the inferior turbinate, and as it goes past the uncinate process where it now sucks out nitric oxide from the maxillary sinus, and the nitric oxide may actually play different roles at different levels of the pathway in the nose. This is open for discussion, and I think there's a lot of area for research in this. So we know now the clinical importance of nasal air conditioning, and there are also studies to show that the relationship between nasal septum deviation and oxidative stress markers. Once you do septoplasty, oxidative stress markers have been shown to reduce. And this is the study I was telling you about, comparison of nasal nitric oxide between inferior turbinate surface and middle meatus. And this is a very recent paper that showed the functional diversity of nitric oxide synthase isoforms in the human nose. So they are now looking at it as how it actually can mediate systemic inflammation in the body. So this is something that I would recommend you to look at it. Just a small little role of, we cannot run away from not working with other specialties if you're going to deal with airway health. And I think the key partners in this are going to be our dental colleagues, because children are not going to come to us until they get allergic rhinitis, and the pediatricians are the ones who are going to see them more than us. But parents are going to take them to see dentists because of malocclusion, periodontal health, and when they can pick up this, we need to partner them to know how to assess the airway and help them to do these airway modifications when we pick them early enough. There is controversy surrounding orthodontics. It's dental aesthetics versus airway compromise. Now, if you only look at it from an aesthetic component, you're missing out one big component of the jaw. But if you look at it from an airway component, aesthetics fall into place very, very nicely. This is a very controversial statement. Extractions and restorative orthodontics may worsen airway condition, but all of you who are dealing with sleep in adults, especially women, you ask your patients whether they have had braces or any orthodontic work with extractions done before and see what the answers are. And we also need to understand that bruxism, TMD, craniofacial pain conditions are more likely to be airway-related symptoms than anything else. I just saw an interview by Kevin Boyd yesterday, and he has done a lot of work on atopy and dentistry, and you need to read some of his work. And this is the PANIC study, also another dental article, Predictors of Sleep Disordered Breathing. So early appropriate orthodontic treatment is thought to prevent SDB in adulthood by modifying deviant craniofacial morphology. Now you ask ENT, why are we not reading these papers? Because we are so used to only reading our ENT papers that we are not seeing these evidences that are being published in dental literature. So we really have to expand our horizons. So now when we talk about OSA, when we talk about the tongue, we always talk about Friedman's classification. But I'll give you one simple clue. You just have to look for scalloping in the tongue, and you need to understand that scalloping is actually a very important sign for breathing disorders. So if you see scalloping in a thin, lean person, it means that the skull is too small for the tongue. If you see it in an obese person, it may be a combination of both. The tongue is too big for the jaw, or the tongue is also, the jaw is too small for the tongue. So we need to have that in mind. And there are also literature in this, also in dental literature, the association of tongue scalloping with obstructive sleep apnea. Scallop tongue is associated with nocturnal intermittent hypoxia, and is also, what do you call that? There are quite a few articles on this. So to give you a key point, when I look at a tongue like this, when I'm going to do surgery in a case, I'll always warn the anesthetic. I said, be careful, because it will give you that there may be issues with when you're reversing the patient. So what's the big deal, and how does it all tie up with sleep disordered breathing? So it appears that the foundation of all problems start in childhood and progress into adulthood. I think we need to now look at this concept of dysfunctional breathing and how it can cause a myriad of problems due to chronic inflammation and chronic oxidative stress. So we need to look at atopy now as a systemic condition and how it is contributing to chronic oxidative stress and inflammation. We know about the Starling resistor model. I just wanted to talk about snoring a little bit, because we all seem to think that snoring is not a bad problem or just a nuisance, but I'm biased and I would say that I would equate snoring to chest pain. It should be in the same category as chest pain, because if you look at the heart as an engine of a car, breathing is a fuel problem. Now we are looking at all the problems in the engine, but we are not even bothering about the problem of fuel. So when we look at snoring in all our OSA patients, they have actually progressed over a few decades. They snore when they're tired or they drink, then they become positional snorers, then they snore in any position, then they're heroic snorers where they provide music for everybody, even outside the room, and then finally they get sleep apnea. So I think we need to look at a serious paradigm shift. Rather than treating sleep apnea, I think we need to pick them up earlier and prevent them from going into an end-stage problem. Of course, there are other compounding factors like weight gain, metabolic disorders, muscle tone. So we need to rethink when we should intervene, because these issues of weight gain, metabolic disorders, and muscle tone may not be the cause of the problem, but the effect of they may be a consequence of an earlier problem. Talking about the tongue, I borrowed this slide from Dr. Yu, a dentist in Singapore. And we are talking about the tongue position, how it actually balances the autonomic nervous system. So the tongue sitting against the palate will actually stimulate the parasympathetic system, versus the tongue sitting down, which actually now drives the sympathetic system. So patients who are mouth breathers with a low set tongue, these are all the things that you start looking at during childhood: nail biting, pencil biting, tongue thrusting, cheek biting, clenching, grinding. They all have got abnormal swallow, they've got decreased salivary flow, their mouth is always dry, restless leg syndrome, anxiety, gastric issues, because even the parasympathetic system has got a role with your GI. So if you look at all our OSA patients, they all have got reflux to some extent. I would say in my practice, it's almost 99% of my breathing disorders patients have got some element of reflux. So is it headaches, neck pain, back pain, or breathing? So we really need to understand that bad breathing is a harbinger of a lot of medical issues. And this is something that I picked up from a Japanese dentist based in the US. We are seeing all the end effects of these problems, from obesity, anxiety, diabetes, headache, snoring, cancer, asthma, chronic fatigue, dementia, aggressive behaviors, allergies, cardiovascular disease. But we don't realize the root cause of the problem may be an underdeveloped jaw, which we in ENT are seeing as a lot of our nasal obstruction patients. Srinivas, can I have another 5 minutes more? Is it okay?
Yes, go ahead.
So we need to understand that the whole atopy cascade, or whatever you want to call it, is going to cause a lot of structural issues, which is going to lead to a functional, or rather a dysfunction, and your body is going to learn how to adapt to these changes. And these adaptations during the early years of life will further contribute to more craniofacial growth issues, which is going to cause more functional issues or more dysfunctional issues, which will lead to adaptation. But as you age, your ability, so you got to look at it at a balance between damage and repair. Damage and repair. A younger age person, damage, repair is very good. An older age person, the capability to repair becomes lesser and lesser, and you're going to see a lot of end stage effects. So we have to understand that we cannot run away from working alone. We have to bring an integrated team approach. I have a very good team here to work with. I've got a very brilliant airway dentist that I work with. And we've got 2 myofunctional therapists with us. And I also use people who are not medical but sort of alternative medicine people, osteopaths, chiropractors, myofacial people, release people, because we need to understand that there's a lot more things that we do not understand, and I think we will bring this up during the case discussion later. Oromyofacial therapy or orofacial myofunctional therapy is here to stay for all of us who are dealing with sleep. The evidence is just too strong. It has shown that it will approximately reduce apnea-hypopnea index by 50% in children, and is 50% in adults and 62% in children. So I do believe that this is an area where more and more ENTs will actually delve into in the near future, because it has to be part and parcel or complementary to our treatment. And also, once you're dealing with adults, once you understand that these are all habitual, or you want to call it a new neurological pathway that has to be developed because they've all learned bad habits from childhood, we have to re-educate them on how to breathe correctly. And I think Patrick McKeown has done fantastic work. He's a big proponent of Buteco breathing techniques. You can look it up in the literature. We also, when we talk about osteopathy talks a lot about craniofacial strain. And what they look at is they try to balance the body. And there are actually literature out there in medical literature telling that how when they release the strain patterns, it actually shows an improvement in things like asthma. And after 3 years of working with them, I am now very dependent on them to actually release the cranial strain before we do any sort of structural work on the nose. This is a thought which I will discuss this more during the discussion. Now, just another digress on histamine and the brain. I think we also need to understand that we need to stop using drugs that cross the blood-brain barrier for allergic rhinitis. I have literally stopped using antihistamines in my practice for allergic rhinitis. I use a combination steroid antihistamine spray, but the only time I use antihistamine systemically is for children who have got, or children and adults who have got a concurrent skin problem. And that too, I use non-sedating, because they have shown that when you take sedating antihistamine, they've studied children exams, the grades have dropped by 40%, or they've dropped 1 grade. They've decreased productivity, increased risk of accident in adults, and they've also shown that the cumulative use of first-generation antihistamines with anticholinergic activity in the elderly is associated with an increased risk of dementia. So with that, Srinivas, I'm done. I'll keep the case discussion for our panel discussion.
Vijay, are there any questions that we could take up? Vijay?
Maybe you can start with the panel, and then if there are questions, you can take in between.
Sure. All right. I think we'll just proceed with the panel. Thank you very much, Jimenen, for a very thought-provoking talk. And I think most of us sort of were hovering around that concept for a very long time. Sandeep for sure has been. So I think this is food for thought and will definitely needs a lot of work to be done. So without further ado, let me just start my presentation and take the panel. And let me introduce my panelists. Like I said, it's creme de la creme. So everybody who's there in the panel today is who and who in the management of obstructive sleep apnea in this part of the world. So I would like to take the pleasure to introduce Dr. Seema Sheikh, who's a consultant ENT surgeon at Inamdar Hospital with keen interest in the management of obstructive sleep apnea. Welcome, Dr. Seema. Dr. Vikas Agarwal, who's the director of his own hospital. He has his new setup in south of Mumbai, I've heard. So going to hear good things from him now. He's had a lot of revolutionary newer concepts in the management of obstructive sleep apnea. Welcome, Dr. Vikas.
Thanks.
Dr. Vidyasagar, who's based out of Vijayawada, who's fellowship trained from the great Michael Friedman, has a lot of publications and also a prolific sleep surgeon. Welcome, Dr. Vidyasagar. And our secretary, Dr. Vijay Krishnan, who's had a lot of publications. I think he's got the publications of all of us put together. He's the secretary of the Indian Academy of Otolaryngology and Head and Neck Surgery and the Indian Association of Surgeons for Sleep Apnea. Last but not the least, associate professor from PGI Chandigarh, which is one of the top institutes in India. And he's got plenty of publications, especially in subjects like DICE, and his thoughts and concepts are revolutionary. Welcome, Dr. Sandeep Bansal. So let me start sharing my screen. Can you see my screen?
Yes, you
Yeah. So let me quickly do a few words about allergy, and all of us know that allergy comes from a Greek term. What we were talking till now is the effect of the combination of allergic rhinitis and the impact it has on sleep. So allergic rhinitis has been reported to have an adverse impact on sleep, memory, quality of life, academic performance, and work productivity. And we all know that sleep is crucial for human mood, memory, endocrine, and immune system functions. And what is OSA? OSA is a condition caused by partial or complete airway obstruction resulting in repeated episodes of oxygen desaturation and arousals. So if you combine both of these things together, if you really dig a little deeper into these things and see why directly does allergic rhinitis and obstructive sleep apnea cause the impact that it has on an individual suffering from both these elements. Now, straightforward, we could come across two problems. One is increased nasal resistance, and two, decreased pharyngeal airway diameter. But we've just heard that things are not that easy. But before entering into discussion and taking the inputs from our panelists in this particular aspect, we'd like to go a little deeper into this particular discussion. Now, the main underlying mechanisms for the association between allergic rhinitis and altered sleep patterns are three in number. As Dr. Jimenen said, the effect of autonomic dysfunction in patients with allergic rhinitis also makes the presentation of obstructive sleep apnea worse and the disease itself worse. Allergic rhinitis symptoms and underlying pathophysiologic changes affect sleep indirectly. And last but not the least, inflammatory cytokines released directly as a result of allergic rhinitis produce fatigue directly, which is also a symptom of obstructive sleep apnea. So if you really bring it down to the numbers, and if we go into literature, this is a study with the highest number of patients enrolled. So 2,600 adult patients who underwent a laboratory PSG showed that 65% of patients experienced nasal obstruction symptoms. That means patients with obstructive sleep apnea diagnosed by a laboratory level 1 polysomnography, 65% of them experienced nasal obstruction as their symptom. So effective treatment of the nasal airway is vital to the complete management of upper airway in sleep apnea. So my first question to you, Dr. Seema, is how often do you see allergic rhinitis coexisting with obstructive sleep apnea in your vast experience of practice?
So, definitely there is a lot of existence there. If you're going to ask me in terms of statistics, it's going to be a little difficult to, put it across because every one of us have different practice scenarios, right? But the more that we are now working with allergy and with OSA, where our eyes are seeing and adapting to picking up more and more of the coexisting allergic rhinitis with OSA.
So do you have a ballpark figure that you can give?
You've put it over there.
This is some literature, but I'm sure in your practice it's different.
I don't have the data to kind of corroborate and say that, but I guess, like we've spoken about the incidence of OSA in our country, I think it would probably match what most of the others see also.
So let me ask Dr. Jimenen from across the seas to see what are your numbers like, if I'm allowed to ask, Jimenen?
Okay. Srinivas, you have to be very definitive here because the pediatric population and adult population are completely different.
We are only talking about adult because you've had a fantastic talk on pediatrics. So this is just purely adult.
Okay, in adults, I'll tell you that almost in allergy, probably about the patients who have active allergic rhinitis is not many. I will say probably because my practice is very skewed because I'm seeing predominantly airway patients. So I will say, if I were to guess, I would say maybe a third of my patients will be active, or even lesser, I would say, maybe about 20-25% at the most, active allergic rhinitis patients. But if you ask me, in my OSA patients, in my sleep or disordered patients,
correct,
if they have rhinitis, I will tell you 100% have got rhinitis.
Right. So I think that's discussion we'll have a little later, whether it's allergic rhinitis or non-allergic rhinitis. But I think, do you have a significant percentage of your patient population having this as a coexisting or a comorbid condition, both of them?
Allergy and OSA?
Yes.
Not that many in adults.
Interesting.
15%.
The question is now open to anyone else who would like to have a different kind of an opinion on this, or if not, we'll take the next question.
Can I just add, Kishore?
Yes.
So see, almost 90% of the OSA patients that we see have some kind of a nasal obstruction or watering or sneezing issue. So some kind of nasal issue. Approximately 50% of that will be because of allergy related matters. So in my practice, if I'm seeing 100 OSA patients, almost 40 to 50% will have allergic rhinitis as an association. It's a
Then let me pause you and ask you one more leading question. Would you say it is seasonal allergic rhinitis or intermittent allergic rhinitis, or you think it's persistent?
So now again, if we have to differentiate this allergic rhinitis into seasonal and persistent, obviously there will be numbers and most of them will have a persistent allergic rhinitis.
So your patient population is persistent allergic rhinitis and OSA?
Most of them.
Fine.
Vijay has to add something.
Yes, Vijay, you have something else to say?
Can I add something?
Yes, Sandeep.
Yeah,
quickly.
I think so. It's very important to again understand like whether it is a IgE mediated allergic rhinitis or a non-IgE mediated.
Correct. So we're coming to that. I have questions specifically on that, Sandeep. Okay. So we'll get there.
Sure.
So if you really look at the possible mechanisms at play, right? Why do you think that we are seeing an increased association between these two, and what are the possible mechanisms at play? I've sort of put two sort of very simple mechanisms here, but I would like to ask Dr. Vidyasagar if you can think of what other mechanisms do you think would be at play other than the simple two ones that I've circled here?
I would definitely add the role of nitric oxide, NO, that to be a part of it, as we heard from Dr. Jimenen. So right. I see that is definitely playing a role, apart from these two that you have mentioned here. The increased Th2 phenotype is the most commonly attributed one, and nitric oxide is the other one.
So are you talking about CRS with allergic rhinitis with obstructive sleep apnea then?
I could add both, actually.
Do you think of any other mechanisms, Dr. Vikas?
Yeah, so see, you have already explained how nasal resistance would increase the mouth, will keep the mouth open. But very, very important thing is when there are secretions draining from the nose into the nasopharynx, the surface tension of the nasopharyngeal surface, which come closer, is increased because of the viscid secretions which drip from the nose to the nasopharynx. And that leads to, collapse of the airways. And the Starling register model, as we all know, that makes the difference, makes the patient from a simple snorer to obstructive sleep apnea patient, because now the airway cannot open. So that again is a very, very, very important thing, which is generally ignored. And the moment you treat the allergic rhinitis properly, the nasal congestion is improved. And second is this viscid secretions going into the nasopharynx, leading to increased surface tension, causing more collapse. That is taken care of. So I think allergic rhinitis treatment is a very, very vital treatment in managing OSA patients.
That point taken. Vijay, do you want to add something to this, or you're okay with the explanations given?
Vijay, you're mute.
Srinivas.
Okay. Yeah.
Can you hear?
Yes, I can hear you, Vijay.
Nothing to add, nothing more to add.
Okay, I think Sandeep wants to say something.
Yeah, apart from, I think, again, this mouth breathing, of course, is a very, very important thing. But from my practice point of view, I think the first mechanism when we talk about mediators, histamines and interleukins, we have a lot of allergic rhinitis, a lot of asthma here, a lot of allergic fungal rhinosinusitis here, probably because of the environment, a lot of greenery and all. Maybe Pune also has, but we are seeing. So I think in my practice, this first mechanism will also have a very important role to play. And
okay, the chemical mediators.
Yeah, chemical
mediators. Sure.
Srinivas, can I just add something, Srinivas, to this?
Yeah, sure, go ahead.
See, Srinivas, in adult OSA patients, right? What I mean to say is when we look at active allergic rhinitis, that's one group of patients, but there's a huge group of patients who had allergic rhinitis during their adolescent years, during their growing years, and then they are no longer symptomatic. But when you look inside their nose, they're still, their nose is still, they've got that typical inflammatory appearance of the turbinates. But here, if you are talking about mechanisms of sleep disordered breathing in allergic rhinitis, what happened during their growing years has caused skeletal issues, which is now contributing in two mechanisms. The breathing dysfunction. One, skeletally they have become narrow because of the chronic mouth breathing from childhood. And the second thing is because of nasal disuse. They are not using their nose to breathe. I mean, Christian Gilbert has talked about nasal disuse.
Correct. Yeah, I point taken. So, to put it in a nutshell, obviously, everybody's brought out these points. So there are mechanical problems, there are neurological issues, and of course, the nitric oxide, which is now making the waves in terms of the mechanisms involved in that is connecting allergic rhinitis and obstructive sleep apnea. Now, that brings us a little deeper into the discussion. So, and Dr. Sandeep actually brought this topic up. So if you really dig deeper into this and you want to talk specifically about what is happening in the nose and the sinuses, you basically boil it down to three things. You're boiling it down to structure in terms of deviated nasal septum, turbinate hypertrophy. Number two, you're talking about an inflammatory disorder involving the sinuses in the form of CRS. And you're talking about persistent nasal inflammation, as Dr. Jimenen spoke, in the form of allergic rhinitis and non-allergic rhinitis. So amongst these things, if I may ask, I will start with Dr. Vijay this time. What do you think may have the strongest association, Vijay?
Allergic rhinitis, I would say. And the next comes, I feel, structural deviations of septum and turbinate hypertrophy, or turbinate, inferior turbinate blocking the airway.
So I think since we are discussing this particular topic, and then I think what percentage of your patients of obstructive sleep apnea actually have CRS? Vikas?
So CRS, if we strictly put it, like for the benefit of the viewers, allergic rhinitis could be simple IgE mediated when you have a sneezing or watering, and could be immune complex mediated, which is chronic rhinosinusitis. So chronic rhinosinusitis, which is within the ethmoid sinuses, which is immune complex mediated, which leads to polyposis, is a small subset of these patients. So in those cases, you will see the turbinate swollen and you have some ethmoiditis on the CT scan. So it's not, I would say 25 to 30% of overall nasal patients would have CRS, but that itself is a big number. And whatever you do, they will keep on secreting into the nasopharynx and cause the narrowing. So I think CRS is a very important entity.
Anybody else on the panel who would want to contribute to this particular question?
So, Srinivas, I mean, I would actually concur with both Vijay and Vikas, but there's a practical issue here. So AR and DNS would be probably the most significant, right?
Right.
But when a patient is coming with an active AR or nasal symptoms, it's going to be very difficult for you to lead him into the OSA part, because his initial complaints to you, whether it's CRS or AR, is not going to be about OSA.
And that's exactly why I brought this discussion up, because as a treating doctor, it's also your responsibility to sort of, let the patient know or educate him about the particular problem he may be getting into.
Exactly. So that's where I was coming at, that when you do this, many a times you will find in practical practice that when these things settle down, the patient's not really so keen to get into OSA.
Correct.
So our statistics, that's the reason why I really can't give you ballpark figures to the percentages, because this is what happens on a day-to-day basis.
And if I may add something,
yes,
it's the other way around also. If patient comes to you with snoring or sleep apnea, and you start talking to him about his nasal condition and allergic rhinitis, especially in my part of the country, they say that is normal. It is normal for them. Sneezing, because it's so much of Congress grass and pollens all around. They're sneezing all the time. They're having rhinitis all the time. They say it's okay. It's nothing to do with it. It's part of the game. So it's vice versa also. Like, the patients are very difficult to be convinced that both these things are interrelated, and they need to be evaluated further, and we need to treat them for both of them.
Sagar, you wanted to say something.
Yes. So the other thing I wanted to add is, like, we also have to differentiate the problem of sleep disturbance, what they have it, from the sleep apnea, what they may have. Any patient with allergic rhinitis, they also have disturbed sleep, not necessarily a sleep apnea. So that differentiation also has to be made. And coming to the numbers, in my practice, I would say nasal inflammation would be primarily constituting around 30%. And septal deviation and turbinate hypertrophy would be constituting more often like 40, 45, or maybe a little more. And then the rest would be by the CRS. So if you want in terms of numbers.
Yeah, because remember those numbers, because we're going to go into surgical management, and these numbers will actually matter when we discuss that.
See, Srinivas, can I just say what about?
Sure.
You see, this is the problem why we need to change the way we are looking at these patients, because we are looking at it purely from an ENT perspective. All right. Now, from an ENT perspective, if you are going to compartmentalize allergic rhinitis and sleep disordered breathing as separate, our patients are not going to buy the story. So when you see this patient, right? When I look at a patient like this, if I'm seeing a 20 to 30-year-old, you are seeing more of allergic rhinitis. but with not much sleep symptoms that they will complain of. But they are sleeping with their mouth open, they get fragmented sleep, they have daytime tiredness, they wake up not feeling fresh. Then as you go into that 30-year-old, that's when you get that mixed picture of the snoring is worsening. They are not complaining about the snoring, but their partners are complaining about their snoring, but their allergic symptoms are now coming down. And then as you go into your 40s, your sleep disturbance symptoms are now predominating, your allergic symptoms are getting lesser. So, and I look at a patient like this, depending on the age group, the first thing I'll ask is, they will ask me, Doc, I'm having all these symptoms. I'll just look at them and say, look, you've actually got a breathing problem. So if you're going to treat this, you have to look at it as a breathing problem. So do you value your breathing as important or not? So once you understand that concept, then you're all encompassing. Then you're going to show him.
So the disease continuum, it's all the disease which is continuous.
So now I'm going to bring another part of a discussion. Why are we looking at deviated nasal septum as a separate component?
Yes, it's a result of chronic mouth breathing and the high arched palate. Of course, that's a different. So because the end of the day, we want to give a take-home message. So I think we will discuss that a little later, Jimenen. Yeah. So if you really look into published literature from the Italian group from Claudio Vicini and Filippo, they've done a fantastic analysis. They've looked into nasal pathologies in patients with obstructive sleep apnea, and this is what the results are like. 70% of OSA patients have nasal obstruction, and it's very interesting to note that 30% of these patients had isolated anatomical abnormalities. 6% had CRS, 18% had allergic rhinitis, and 26% had non-allergic rhinitis. So if you really look at where this is actually going, 95.4% of patients with nasal inflammatory conditions such as allergic rhinitis and non-allergic rhinitis suffered from nocturnal respiratory obstruction. So it's just not the static obstructions that we need to really look into, but we really need to look into these allergic rhinitis, the way they present, and it's, I think, high time we give their due into how they sort of manifest in the whole backdrop of obstructive sleep apnea. Anybody would like to comment on this particular paper, and would you all agree on this?
Would agree with that.
Yeah, I would agree with it. This is classically what we see.
Exactly. Okay.
So what is important to understand is that nose treatment is, if not primary, it's pivotal.
I mean, it's, yeah, that was my final slide, Vikas. All right. So let's go a little further. And I would like to ask this particular question. I would like to start from Jimenen. What is your take on positional obstructive sleep apnea and nasal obstruction? And what phenotype kind of patients do you see with this kind of a subgroup of patients? What kind of phenotype?
First of all, I'll tell you that I've never really related this to the sleep studies, but what I generally see in this, because positional OSA is only one part of it, but generally speaking, you will find that the person will tend to sleep on the narrower side.
Correct.
And when I say narrower side, we have to look at the nose as a three-dimensional box. So it's not just looking at the deviated septum, you also have to look at the middle meatus. So I very simply look at it in two zones. When you put your endoscope into your nose, look at the anterior portion where the inferior turbinate is and look how the septum is inferiorly. And then angle it 30 degrees or 45 degrees above and look from the entrance into the middle meatus, middle turbinate. And then you see the narrowing on which side. And you will get your rough idea on which side is the narrower side. And most often than not, that is the side that they tend to sleep on. Now, there are caveats to this. Trauma and previous orthodontic, especially restrictive orthodontics, bicuspid extractions and setback of the maxilla can change this finding. So
orthodontic surgery, you mean?
anything, any orthodontic surgery or restrictive ortho, anything that you will see will say this. And also, if you have had this non-trauma, this kind of virgin cases, if you look in the ear, you will see that there's a slight difference in the past tensor retraction in the ear. So the ear that is usually more retracted will corroborate with the side which has got the compensatory side, usually. But very bad deflections, you can see it also on the same side as well.
Vijay?
Yeah, that's what the recurrent OMEs in children, the mandibular advancement devices or the dental realignment will help to prevent OME by pulling the maxilla forward, thereby makes the tubal function better. That's what I think.
Correct. But my specific question is positional OSA. Obviously, positional OSA, wherein the supine OSA is double that of non-supine OSA, and nasal obstruction, especially when patients have gross septal deviations. Or what kind of patient phenotype are we really looking at? Do you come across these patients?
Can I just make a statement here, Srinath?
Sure.
Yeah. So, to tell you very honestly, I don't look at this part at all, because my treatment of OSA will be based on my nasal obstruction, irrespective of whether the patient is positional or non-positional. So for me, it really doesn't matter. I will be looking more at
the reason why we are asking why it's been.
I'm sure for discussions. I'm just answering that question. Yeah.
Can I add, Srinivas?
Yeah. So what I'm trying to.
Sorry.
Yeah. The reason why this discussion has been brought in is because in most of these kind of patients, in positional OSA patients, just correcting the nasal pathology most of the time can actually reduce the disease burden.
Absolutely. See, yesterday I have seen a patient, husband of a doctor, had the same problem. Twice sleep study, AHI is less than 5, but he is badly disturbed, snoring. So it is a case of upper airway resistance and there's a gross septal deviation on one side. He said, I have no problem, but he sleeps better on that side, as Dr. Jimenen said, and he has problems only on going on the opposite side. So both of you have absolutely put this slide correctly.
So the next question, now slowly we're moving into management, and this I would like to start with Jimenen. How many patients with PAP that you've given complain of nasal obstruction post-PAP, and they say that they are not able to use it?
A very difficult question for me to answer, because as a prerequisite for PAP, all my patients are on sinus rinses and nasal steroids.
Right.
So if they're on PAP therapy, I very rarely find that they are complaining that they cannot tolerate it because of nasal obstruction. But there is a subset where there is obvious obstruction. There's obvious nasal obstruction, and they find that these are the ones who tend to pull off their mask without realizing it in the middle of the night.
Correct. Exactly.
And, they get a lot of sleep disturbances. Now, you'll ask me, why am I putting them on the CPAP without correcting the nose? Usually, this small minority of them are not surgical candidates because of medical problems. They've either had a recent bypass or they're on multiple blood thinners and stuff like that. But if I'm pushed to, they've got no choice but to undergo nasal surgery.
So the reason why I'm asking you is also because if there is a history of allergic rhinitis, it has been shown that actually nasal congestion gets worse. So it's very important for us as ENTs to get that history out and correct those nasal pathologies before we just, and it's also important that we sensitize our patients, because according to the rule, we are supposed to give them CPAP, right? So Sandeep, do you have anything else to sort of contribute to this?
I think so.
Because you come from an institute, and you what are your protocols like?
Like, frankly speaking, if we have to give a PAP to the patient, I refer to my pulmonary colleague.
No, but before you give them a PAP, do you
Yes, yes.
Do you sort of analyze the nose and take history for?
Definitely, and we try to take care of the nasal problems. And fortunately, in the recent times, we have been getting, referrals for the nose examination before the patient is put on PAP. So that is a very positive sign. Collaborating with our pulmonary colleagues, and they have been sending patients, and they started realizing that if we correct the nasal problems, the compliance to the PAP has increased, and I think they have been sending patients for that.
So, and I would like to take the opinion of Vijay, what do you think, Vijay?
I would say more than 50% initially complaint of nasal obstruction and congestion when we immediately put them on CPAP. And other patients who are regularly using CPAP, I would say 10 to 20% maybe coming back with the nasal obstruction and removing the mask and all those things when they get allergic rhinitis or when they get nasal congestion. And we now I'm actually doing a paper on assessing the nasal resistance before putting them on CPAP, so that I'm assessing whether they need any nasal intervention, and those people who need nasal intervention, what is the cutoff value of nasal resistance over which they need nasal intervention. That's what with the rhinomanometer I'm assessing. Once I come back with a good amount of numbers and value, I'm able to share it with you all.
I think so. Thank you, Vijay. So I think the reason I brought this paper out is it's a very nice paper by Ed Weaver, who's concluded that, allergic rhinitis may predict who will have difficulty with PAP therapy because of less favorable changes in nasal congestion. And we know that more than static obstructions, it is the nasal congestion which plays a role in terms of CPAP compliance or in terms of your success for multi-level surgery. So I think this is something that is very important that we ask our patients before we go on the journey with the management of obstructive sleep apnea. And here's another paper. Yes. Yeah.
Srinivas.
Yes.
It's just not only the nasal congestion, if I may add, many a times, they describe it as the dryness also. So unless you really told them, even the dryness causes them to have nasal issues.
Correct.
And you have to specify to them to use a humidifier.
Correct. Correct. And this is another paper from the Stanford group, which shows that just doing a nasal surgery on CPAP, on people who have been prescribed CPAP, have actually increased their compliance from 38 to a whopping 90.2%. And this is a significant group of patients. There are a lot of patients who may not be candidates for multi-level surgery. They may not be, or they're very happy. They want to use a CPAP, but they're just unable to use this because of what's probably happening in the nose. And there is robust evidence to sort of show that treating allergic rhinitis, reducing their nasal inflammation would definitely improve their compliance as well.
Another thing I want to add.
Yes, Sagar.
Yeah, these are the patients who would opt for a full face mask. See, while they are doing a titration, when the patient is not tolerating a CPAP, obviously our technician is supposed to ask them to use a full face mask and try them. So the patients who have used the full face mask and they are comfortable with that, these are the patients who obviously have the nasal obstruction. And this would contribute to approximately 1/3 or 1/4 of the patients who don't tolerate, which means like approximately 25% of them would be having this problem.
Srinivas?
Yes.
Are you going to be talking about myofunctional therapy?
Yes, yes, yes.
But I won't bring it up now.
No. That question is coming, and that's for you. So the problem is just not with one kind of conservative therapy. The problem with nasal obstruction is also for the other kind of conservative therapy, which is the oral appliance. And nasal obstruction can also interfere with oral appliance treatment in OSA. And this is one of the very good studies that I brought up. in a study of 38 OSA patients, the reason the N is very less is most of these cases, this is the highest number. It's somewhere between 30, 38, like that. So who are treated with oral appliance, the nasal resistance was increased in a group of 12 non-responders when compared to patients with oral appliance responders. So if you have a set of patients who are not responding to oral appliance therapy, look in the nose. And look in the nose, look outside the nose as well, right? Maybe the piriform aperture itself is very narrow, and there is loss of coupling and all those things. So, well, that's a different Pandora's box. So, two conservative methods of management, both CPAP and oral appliance therapies, will not do well if the patient has nasal obstruction.
Srinivas, can I make a comment on that, Srinivas, please?
Yeah.
See, this is a big problem, because generally the people, you have to understand that all of us here are very focused on airway and sleep disordered breathing. But to a general ENT or even to a general respiratory physician or people who are dealing with sleep apnea, they all have this mindset that the gold standard of treatment of OSA is CPAP. The second choice is oral appliance or a mandibular advancement device. And I think this is totally wrong.
Yes, it is.
And I think this message must go out to people who are not focused in airway but who are still treating these cases, that they need to understand that we have to target our treatment according to our patients and not just, if this doesn't work, I'm going to use this.
Yeah. And they would give them oral appliance with CPAP and a chin strap. Yeah. And then he's completely choked. I've had a patient like that who's been given an oral appliance and a chin strap and a full face mask, and he's obviously not able to breathe. And there is so much leak because of the advancement device, and then the mask doesn't fit, and it's just a mess. So, what kind of strategies do you adopt in these kind of patients, especially who are not able to manage CPAP? I'll start with CMAP, and let's start with, you're not going to jump into surgical management, right? So here is a patient with allergic rhinitis, with structural issues in the nose, having nasal obstruction, is not able to use the gold standard therapy. What would you like to do? How would you like to start the journey for them?
So eventually, definitely medical management, at least for about 2 to 3 weeks, right? We start with the sprays because by this time, they're mostly persistent allergic rhinitis anyways. So you've got to give them. Now, the problem actually that comes here is that waiting for that 3-week period, if he is a patient with very severe OSA, or if his probably you've got his sleep study done and he's come back with very low saturation, that's where you really have a challenge. So how do you try to get this guy to understand that his OSA treatment is going to be delayed a bit till we take this medical and conservative management forward? But obviously, first line of management will always remain medical. I will give it at least 2 to 3 weeks for him to see the response on that, unless there is a very gross structural deformity, for which then I will counsel him that needs to be addressed.
So then my next question is an extension. How would you want to start the journey? And what set of patients will you actually select for medical management? Are there a set of patients that you would see that, okay, these guys, you want to give it a shot, or this guy is a waste for medical management? Who are these set of patients?
So the typical runners, the runners with a lot of, say, discharge, mucus accumulation, you see in the nose, you see turbinate hypertrophy with, say, mild DNS, not really that bad. These are the ones that I would definitely start off with medical therapy.
So I would like an input from all of you, please, because who are these patients that you would want to start? Who would you select for medical management?
So I generally get a CT-PNS done at the first visit itself. If I see anything in the nose, any nasal symptom, I get a CT-PNS. And if I see a gross septal deviation, if I see a gross turbinate hypertrophy, if I see polyposis inside the sinuses, I know that long term, this guy is not going to respond to medical management. So this guy is not the candidate for medical management as regards the nose. If there's no polyposis or chronic rhinosinusitis in the ethmoids, if there's no gross septal deviation or just a spur or something, if there's not gross turbinate hypertrophy or concha bullosa, and the patient has, like Seema said, some running nose, some this and that, then definitely this is the patient who is there for medical management. And if I see not a very heavy OSA, I do not see a very big palate or a big tongue, then definitely I would take this patient for a medical management.
Vijay, the same question for you. Which subset? So the classical allergic rhinitis patient are the subset of patients, is it?
Yes. I don't think anything more than that.
Then my next question would be
just one point, but
yeah,
I mean, I'm sure all of us are saying the same thing in the sense that this medical management is interim. Okay, we are not saying that this subset of patient is only for medical management. It's an interim period before we get into the actual OSA.
So obviously, my next two questions would follow that. What kind of medication would you prescribe? See, obviously, we need to understand that we are managing OSA along with the comorbidity, which is the nasal obstruction and allergic rhinitis or whatever, because they are the set of patients we have taken up for medical management, right? So my question is, what is the outcome measure? When do you think that this guy is sort of reasonably, where do you draw a line saying that, okay, this guy is responding to your management, and what are all the medications that you would want to try before you say, okay, this is it, hands up, I want to try something else as a modality of management? Sagar?
I would primarily try the intranasal corticosteroids and intranasal antihistamine.
And any particular reason why, other than the one that JJ said, Dr. Jimenen said?
The antihistamines definitely cause little amount of drowsiness, apart from the reason.
Because now we have all the newer generation ones, we have the newer generation ones.
Yeah, that's what I'm saying. Apart from belastin and to a certain extent fexofenadine, the rest of the antihistamines definitely cause sedation. I find in my practice, the intranasal corticosteroids and the intranasal antihistamines give a very good response to these patients, if at all they are responders. And if needed, I have also given a pulse dose of oral steroids in selected patients. But oral antihistamines nowadays I'm using is the belastin.
So what is your outcome measure then, Sagar? When do you say, how long will you give the medication? Because this can keep on continuing, because these are allergic rhinitis patients, right? They're going to be like that. So are you going to give it for how long? Because the moment you may stop, the CPAP compliance might go down.
So it again depends on how we stratify the patients, whether it is seasonal versus persistent, and whether it is mild versus moderate and severe. So if they fall into the moderate and severe and persistent, those are the patients I would have a mental backup that these are the patients, if they are not responding with the final outcome of not improvement in the nasal obstruction, then I would plan them for surgical treatment after 3 to 4 weeks. These are the patients that I would select them for a surgical category.
Sandeep, from an institute practice point of view,
how
would your management differ?
See, I think I would first like to go for a diagnostic nasal endoscopy. That would help me, see whether.
No, diagnostic nasal endoscopy is done. These are, we've already decided that these are allergic rhinitis patients. All right.
Okay. So intranasal corticosteroids, as Sagar says, and I would like to add nasal douches also to this.
How long?
4 to 6 weeks minimum.
And then you will stop?
No, then I'll do a nasal endoscopy again if we are seeing that there is like the patient, it has to be some visual analog scale kind of thing only. So with practice or with you will know that yes, patient is responding, patient is doing better. And if it is a seasonal thing, we can just stop the intracorticosteroids. We can just continue with the nasal douches and see if the patient is able to tolerate the CPAP better. I am not very sure if surgical management for allergic rhinitis and how much would it help,
So let me rephrase the question and ask. So supposing you decide on doing a multi-level surgery for whatever reason, he's not CPAP compliant. You see a lot of static obstructions and there is a coexisting allergic rhinitis. So would you continue allergic rhinitis management post multi-level surgery?
So, but then if I'm taking up the patient for surgery, I would like to correct the nose, whatever I can.
But he's got allergic rhinitis.
Reduce the turbinates at least. If there is
okay,
no
but
deviation.
But that's not going to reduce the disease, right?
Srinivas.
Sorry.
Can I add, Srinivas?
Yes, all of you can add.
This is a beautiful discussion. I think this is the reason I said if we do a CT scan and we see that there's nothing inside ethmoids, there's no gross septal deviation, and this is pure allergic rhinitis, then intranasal corticosteroid, because it will take care of both the histamine pathway and the leukotriene pathway. It will take care of both the pathways lifelong. That is the prescription that goes home with the patient, because he has to take it. If it is seasonal, he take it during that season. If it is persistent, he'll keep on spraying it. So this is what I said, do a CT scan, then you are very sure whether there is a surgical issue or not. If it is polyposis, you have to operate and then give steroid. If it is anatomical, you have to operate. Otherwise, lifelong medical treatment will be explained to patient, and that goes side and side. And that is the answer of your second question. How long will you give it? Intranasal corticosteroid, lifelong for allergic rhinitis patients.
Dr. Jimenen, you always have something else. So why don't you chip in?
See, the thing is, Srinivas, we have to understand what is the difference between allergic rhinitis and asthma. I always look at asthma as the deciding factor. If a patient, have you ever seen how a respiratory physician, patients have got no qualms about taking steroid inhalers for life.
Correct.
For asthma. Why are we so hesitant to give our patients intranasal steroids for life?
Correct.
I'm a walking example of using intranasal steroids. I'm coming up to 37 years now. And I will definitely wash these patients. You see, again, the saline rinses, right? I joke with my patients and I tell them, I said, we are looking at a breathing problem. But what are we breathing? We are breathing air. So it's like putting fuel for your car. But does it matter also the quality of your fuel? Now, we can set everything correct. But if you're breathing bad quality air, don't you think it is a right for us to clean our nose every day? And even by breathing polluted air, even if it's non-allergic, you're going to have, it's going to cause some form of rhinitis, whether you correct the structure or you don't correct the structure. So I think we really need to understand that these treatments that we are going to do, given the current situation of the world, where we are living in urban, polluted environments, this is definitely something that has to be there pre-treatment and post-treatment.
Correct. That's exactly the discussion that I wanted to bring in.
Srinivas,
Yeah.
just to answer that
quickly, Seema, I think. Yeah.
Sorry.
Quickly.
So when you have decided the patient is an AR patient,
correct,
I would definitely start off with the ICNS for about 3 weeks, and I would not do the sleep study or the CT scan on the first visits. I would wait to do the scans and the sleep study after I've controlled the AR. That would give me a better picture of what it is. And if at that time the structural deformity is obvious and the patient has responded, and like your question was very specific, multi-level, then I would still continue with the medical management post-surgery also.
That's exactly the point that I would like to sort of bring on.
I wouldn't want to do the sleep study if it's a fresh patient and come on that same day. If I've identified him as AR, I would refrain from doing any of the diagnostic tests till I get his AR under control a bit.
So what if he comes out with all symptoms of OSA, typically EDS?
Agreed, Srinivas. But see, when you're going to do a sleep study with a full-blown AR picture uncontrolled, you're going to get skewed results. You're going to get results which would be very different, which you will get after you control his
So
AR.
you're saying you would land up overscoring your patient?
Possible. And I think 3 weeks is not a very big time for us unless he's in some imminent danger. So
Right.
3 weeks of waiting is not a big time for us to reassess him afterwards, because anytime if you do either a CT or a sleep study, you're going to get all that mucus out there in the pictures.
Sure, point taken.
And Srinivas, if you're taking the patient for a multi-level surgery,
Right.
then and patient has nasal symptoms and you see this, the CT scan would definitely be done before we take up the patient.
So since we are talking about medical management, and I think nobody else has as much as experience on myofunctional therapy than Dr. Jimenen and dear friend, I think both of them are fantastic in this. And I've also sort of got onto this. There is huge evidence. There's a recent paper there by Maria Carrasco saying also, speaking about the same thing, that the role of myofunctional therapy. And all of these patients, once post-surgery, you put them on myofunctional therapy, let it be a simple tonsil adenoid, let it be multi-level surgery, they do well. So, Jimenen, can you just give us, because we're all very new to myofunctional therapy, can you just quickly give us a little insights into this form of treatment?
See, Srinivas, when we're looking at sleep apnea today, right, we know that it's probably an end-stage spectrum from dysfunctional breathing. And one of the components for the issue is it is not getting the tongue in the correct position. So now you see, when we look at that flow of air through the nose into the lungs, to maintain that flow, you have to have lip seal and you have to have tongue posture. So what we are seeing is, when you see a patient with some form of rhinitis, these are the ones that you see that there's nasal problems. But when you see those without any rhinitis, you almost invariably will find an issue with the tongue. The tongue tone is either very poor or they've got some grade of tongue tie. And a lot of these patients are actually posterior tongue tie. And these are all functional tongue restrictions. So they can't place the tongue completely in the roof of the mouth. So the whole concept of myofunctional therapy is to get the lips and the tongue to do the correct physiological function to balance everything out so that we can get our patients to breathe nasally. So by just correcting the nose without correcting the myofunctional component, we are not doing anything for our patients. And these are all evidence-based now already. So that's why I said we need to really look at where the problem is. So the whole concept is, no matter whether pediatrics or adults, now when we work with our patients, we work in four stages. So a preparatory phase, a structural correction phase, a rehabilitative phase, and a maintenance phase. So that maintenance phase is when you put everything in system, the whole system correct, the function becomes non-forced or it becomes more sustainable. So myofunctional therapy is started immediately in the preparatory phase. So in adults, no matter what grade of OSA, see, I have not talked about CPAP users. See, for me now, PAP therapy is no longer the gold standard. Now, this is new for anybody. I don't consider PAP therapy as a gold standard because we find that even patients who have put on PAP, after 5-6 years, you find that their pressure requirements keep increasing.
Correct.
Why is this happening? It is because they are aging and their tone is getting lesser. So the collapsibility is getting more with age. And when the moment the pressure increases come, you will find that their ability to use the CPAP becomes an issue. And this can be the issue even after nasal surgery and all of that. So now you understand why myofunctional therapy is very, very important. So in the preparatory phase itself, nasal rinse, intranasal corticosteroids from ENT, breathing re-education, myofunctional therapy, and then we also work on cranial strain as well, and that's a whole different ballgame altogether. Now that we are beginning to understand the role of cranial strain patterns, we realize that once we work on the cranial strain patterns, our end results after 3 to 4 years, we are seeing less inflammation all over. And I think that is the time now we can think about reducing our corticosteroid use because it really works. So in that first phase itself is very important, and this is going to take months. Right. And then subsequently, then you come on to your structural correction phase. And this is where you really have to decide how much you're going to expend, what type of expansion are you going to use, what type of nasal surgery. So doing more may not be the answer. Doing less may be actually very good, because doing less is more, and then utilizing myofunctional therapy to get the final result.
Yeah.
But if you don't correct the structure, then in your rehabilitative phase, you're going to have problems. If you don't respect tongue space, if you cannot get your tongue coupling by not correcting the whole craniofacial structure, this is including nose and the maxilla and the mandible, then you cannot get your tongue to sit correctly in that space. And this is where you will relapse into your old system kind of a thing again.
So the whole discussion is basically on peak rate, right? So whenever you give a CPAP or you do surgery, you're basically trying to increase the peak rate value, and MFT sort of helps exactly in that. And of course, bringing back the lost coupling back.
And this is what we were talking about, the turbinate posterior and turbinate hypertrophy, whether we should be dealing with it.
Correct.
It may have a role in actually maintaining peak rate, and then which actually has an indirect role on the pharyngeal collapse, which is going to get worse with age. So all this, so a simple dictum, I know wrong group of people that I'll be saying this, I'll be putting my neck on the chopping block. If you see a palate and a tongue that needs surgery, go out, take a step out of the box and see if the box is adequate first before you touch. Because one of the limiting factors in myofunctional therapy is the moment you do tongue surgery and you do palate surgery, you are touching muscle. If you cause scarring in the muscle, you cannot rehabilitate these patients.
Correct, because the muscles are attached to the skeleton and the skeleton is flawed.
Yes, so we really have to relook this concept, because the moment you convert muscle into scar tissue, end of story with myofunctional therapy. I can tell you from experience, because I had RF on my soft palate, and just purely RF on my soft palate, I can't get my posterior. So now it's like having vocal cord palsy. When one cord doesn't move, you're trying to overcompensate on the other cord to bring it to come into contact. So what should be naturally the posterior tongue sitting on the palate, I can't get to do that with my myofunctional exercises. So now I'm overcompensating with my posterior tongue to try and touch it against the palate. So I'm struggling.
Right.
And that is only with RF.
And yeah. So let's now slowly enter into the surgical management of OSA and allergic rhinitis together. So when you talk about surgical management, yes, Vijay.
There are a few questions from the audience.
Sure.
Can you take it before we...
Yes. In the chat box? Yes. Okay, so Dr. Prakash Munka, well-wisher, welcome change in OSA surgery approach. In all the meetings, if you remember, I used to start with the nose, but most pass on to DICE, leaving nose all alone. Yes, sir. Dr. Vikram Khanna, should we do inferior turbinoplasty and adenodectomy as a routine in the addition to allergy testing and immune therapy? Dr. Vikram, I think we're going to talk about that when we talk about the surgical management. We're going to talk about the philosophy of allergic rhinitis and OSA together, and we're definitely going to touch upon that point. Sri Mandir Kumar, how to manage simple snoring? If nitric oxide is one of the cause in the subset of patients with OSA, how do you recognize it? JJ, would you like to take that question?
I think whenever it comes to snoring, right, I think we need to identify the source of the problem, target where the issue is. And I'll tell you, the younger the patient, you will find some problem in the nose.
So he says that if nitric oxide is one of the causes, which subset of patients and how do you recognize them?
And this is an area where nitric oxide, that study which I showed you that was recently published in July this year, is something that we really need to look at, because if you look at that study, it tells us that try not to touch the turbinates. That's the idea that I get, because treat it conservatively. If you have to do minimal amount of surgery. you don't create a space compromising a vital structure. If I were to give an example, it's like if you take asthma as an example, you don't take out lung tissue to improve breathing. That turbinate is part of your breathing structure.
Right.
So do the bare minimum, see where the problem is, whether it's skeletal, soft tissue, do the bare minimum and treat it accordingly where the source of the problem is.
In fact, if you look back, some of the papers were talking about decreased nitric oxide in patients in whom large middle meatal antrostomies were done, which actually, and then of course that's a different discussion altogether. Dr. Saurav Chanda from Kolkata says,
I think Srinivas, he was asking how you measure the nitric oxide.
Nitric oxide, yes.
That's by the FeNO test, no? Fractional exhaled the nitric oxide test.
Correct.
That comes with the mouthpiece that is attached. So
that has to be done in a, it's not easily available.
It's not a clinically available test, Kishore. So doctor, he has to understand that managing simple snoring is not even
managing
as easy as managing OSA. Yeah, because simple snoring could be from the epiglottis, from the nose, because of muscle relaxation and multiple reasons.
Correct.
So simple snoring is a very, very difficult thing to manage.
Dr. Saurav Chanda from Kolkata says, does allergic adenotonsillar hypertrophy cause OSA? What is allergic adenotonsillar hypertrophy? I think what he's trying to ask is adenotonsillar hypertrophy as a consequence of persistent allergic rhinitis. Does it require surgical intervention or no? I think Dr. Jimenen answered that, but I would probably ask Dr. Vijay to take that question.
If it is after a trial of medical management with the nasal spray and medication, if it is not resolving, then we plan for surgery.
Right, but then what after surgery?
What after? Pardon?
I mean, because of the allergy, there is adenotonsillar hypertrophy as a consequence of allergic rhinitis, and you have done a surgical intervention. Would you give medical management after that, or do you do any kind of immunotherapy or things like that?
After the surgery also, we continue with nasal steroidal spray.
Yes.
And still, if it is not resolving after 3 to 6 months of medication, then we have the option of immunotherapy to...
Perfect, Vijay. I think that's about it, right?
Srinivas, I just got one comment on this. We always forget to talk about this. See, in addition to medical management and surgical management, don't forget that there's a lot of causative factors that actually drive allergies. Smokers in the house, pollution, pets at home, dusty environments, and even diet as well to some extent. So all these things have to come together as part and parcel of treating an allergic patient before we decide that the tonsils and the adenoids are actually a problem.
And also we need to understand that this is a disease continuum.
Correct, exactly.
You can't. So let's come to.
Sure. Could I add one word to it?
Yes, Vikas.
If you believe that the adenoid and tonsil hypertrophy is purely because of allergy, then it does not harm to give a shot of oral steroids for a week or so. The moment you give oral steroid, everything will shrink and the OSA symptoms will disappear. Then you can follow up on the intranasal corticosteroid spray and then treat allergy medically as well. If after 1 week of oral steroid it does not go, then it requires a surgical treatment.
Yes, point taken.
Caution on oral steroids. And there was an article that came out a few years ago that talked about cumulative total dose of oral steroids needed to put a patient at a lifetime risk of developing osteoporosis and diabetes. The cumulative dose in a person's lifetime to cause the risk is 1 gram.
Okay.
So that's very easy to get. You treat cerebral palsy, you already reach 20% limit already.
Yes.
Okay. And now with COVID.
Yeah. So when you talk about surgical management of allergic rhinitis and obstructive asthma, your focus is sort of in 4 directions. So it could be nasal valve, which is very common in patients with allergic rhinitis. It could be turbinates. It could be the nasal septum. It could be septal swell bodies. It could be various combinations of all of these. Now, one second. So I would like to bring in this concept of septal swell body. I'm sure all of us are seeing this particular septal swell body in our patient subset. Sagar, Dr. Sagar, would you like to comment on the role of septal swell body as a part of your overall management?
Yeah, septal swell body.
Because this is something which is hugely popular in the US, and people talk a lot about this.
Exactly. It has multiple names. It goes by septal swell body, nasal swell bodies, Kishelbach's ridge, so on and so forth. So it is definitely one of the important findings that we see just above the inferior turbinate at the level of the nasal valves, anterior to the middle turbinate or the septum. And it is like a fusiform dilatation that is located in the septum, which is actually sinusoidal. It is like a cavernous sinusoidal pattern that is over the septum. And this definitely adds on to the nasal obstruction, especially in the patients with obstructive sleep apnea with the allergic rhinitis. These patients, especially the septal swell body, do respond to your intranasal corticosteroids as well as to the positional management. But if it is not responding, then it becomes a irreversible phase. Then it needs to be addressed. You can address it either by radiofrequency insertions or with your coblation. These are the ways that it can be managed, and it shrinks well.
Dr. Sandeep, do you see this in your patient population? And if so, how do you manage it? Dr. Sandeep?
He has to unmute.
Yeah. We have been using a coblator for this to shrink these swell bodies. If it is not associated, like if it is purely just a swell body, no septal deviation, of course.
Right. Vijay, do you see this in your patient population as well?
Yes, it's very common, and usually it is missed and think that it is a very high septal deviation. But usually it is present on both sides of the septum at that particular position what Sagar was explaining about the inferior turbinate and anterior to middle turbinate. This is one of the key area for the airflow.
Sure.
So definitely reduction of this swell body helps in patient breathing.
Right.
I just wanted to add that if for people who do not have a radio frequency or coblation, simple cautery, they can just touch it with the cautery and it will shrink. So with the cautery pin, they can go inside and shrink it with the cautery as well. So there's absolutely no harm.
Submucosally, right?
Submucosally, right.
I've even heard of people like doing it on the mucosa itself, Srinivas.
Yeah.
That they just ablate.
It can be done.
Exactly.
Done with a lot of crust formation.
Yes. Yes.
But Srinivas, about the septal swell body, right? I used to do a fair bit of it, but now I've actually taken a step back because there is a reason, maybe a reason why the septal swell body is there. It may be something to do with humidification and moisturizing the air. If you look at it, the septal swell will actually compensate based on how bad the deviation is. So sometimes when you see on the wider side, you will see that there is a very huge septal body. So these structures that we are seeing in the nose are actually, they are some form of compensation because of altered airflow. So then we have to take a step back and say, why is there altered airflow in these patients? So, I mean, if you can understand that, again, we are going back to the transverse diameter of the nose. If from this, everything is going to come like this, you see, if you have a space like this, everything is going to be symmetrical. But the moment the space comes closer, even if you look at that picture that you have screenshot, right?
Right.
You can see the area that's being blocked is the anterior face of the middle turbinate,
Right.
which is how airflow actually needs to go.
Right.
We have to be very functional when we are doing this. We really have to assess this and decide how much, and in conjunction, how much are we going to do elsewhere as well.
Right.
I think most of the questions are answered by a simple answer of rhinomanometry, which can evaluate the nasal resistance.
True.
That way we can compare pre and post whether we need intervention or not.
Yeah, a lot of chicken and egg stories can be answered.
Yeah.
Right. So the next thing which is very common in allergic rhinitis patients with OSA is nasal valve collapse. And I'm sure most of you see that. I would again start with CMUB. Spreader grafts are something that most ENTs with plastic trainings do, and they use that a lot. And we as sleep surgeons use a lot of the technique called nasal valve stabilization. So one quick answer from each one of you. What would be your technique of choice? If you see a patient with internal nasal valve collapse, what would you do in your patients? The question is open for everybody.
A disclaimer right at the start, Srinivas, I have never really had to touch that in my practice. So I won't answer that question.
Sure. Vikas?
Yeah, so basically, most of the Indian noses are wide, not very steep. And nasal valve generally is a problem because of the septal deviation combined with the turbinate. So 95% of my patients improve only with the correction of the septum and the turbinate.
What also happens, Vikas, is most of the times, and you would have seen it in your practice, if there is a gross anterior deviation, that deviation is actually supporting that the lower border of the upper lateral cartilage. And the moment you bring and correct that, there is suddenly it sags in. And at the end of the repair of the septum, you would see that one side is actually sagging. And I'm sure you must have seen that in your practice as well.
Yes.
So that's the reason why you generally don't really need to touch this part initially.
Sagar, do you have any points to contribute? What do you do?
Yes, I would go with the nasal valve stabilization. Having said that, we have done many procedures of this in US, but coming back to India, hardly done many. Even though I brought a lot of the kits with me from US, still I do have them. The MITEC anchor system.
Yeah, that Michael Friedman's technique.
Kit, yes. Yeah. So I would have done maybe 4 or 5 so far, even though I had brought 15 of them with me, but only 4 or 5 so far, which tells that this is not that common in our country when compared to US. So, but still it do exist.
Wider.
Yeah, and also the standalone existence of this external nasal valve collapse is also, the incidence is very less in our population when compared to US. In US, I would have seen so many. The minute I asked them to breathe in like this, I would have seen the collapse. But here I don't see that many. So
what about Jimenen, in your patient subset, because Malaysia is a multi-ethnic melting pot, what is your take?
I see this only, again, in Caucasian patients only, you know. But
the expats.
Yeah, the expat groups. Because they've got this very narrow high nose.
Correct.
But I've got no experience with this, so I send it to a facial plastic person.
Okay. So next question is, what percentage do you think is an inferior turbinate contribution to the whole gamut of things in patients with allergic rhinitis and sleep apnea?
100%.
So to throw some numbers at you, this is a study, 67 patients with either habitual snoring or OSA found evidence of inferior turbinate hypertrophy in 97% of the patients, and increased nasal resistance and acoustic rhinomanometry, what Vijay was talking about. He was talking about regular rhinomanometry. This is acoustic rhinomanometry, 93% of the patients. This is from Big Kotecha. So he's big into this acoustic rhinomanometry. And if you really look at the action statements, clinical practice guidelines in allergic rhinitis and endorsed by the American Academy of the Otolaryngology of Head and Neck Surgery, in statement number 12, it says clinicians may offer or refer to a surgeon who may offer inferior turbinate reduction in patients with AR, with nasal obstruction and enlarged inferior turbinate who have failed medical management. So now, when you talk about medical management, right, you need to understand, I mean, when you talk about turbinate management, you need to understand two things. There are two different philosophies. One philosophy is you either contract or modulate the nasal mucosa on the turbinate, or you zoom out a bit and you do corrective surgery to the nasal cavity to improve the airway. So there are two different ways of looking at managing inferior turbinate. So I would like to sort of take each one of your opinions. I would start from Vijay. How would you decide which kind of path that you are going to go to manage these patients?
You need to ask soft tissue and bony thing?
Yes. So one set of procedures wherein you are actually going to address whether it is the turbinate, the concha, or the mucosa on the turbinate. One path is to actually do and widen the piriform aperture. So which ones which are the subset of patients you would do the first, and which are the ones that you would select the later?
The first thing is the space between the medial wall of maxilla and the inferior turbinate space. If it is very much less, and if the concha is very much closer to the medial wall of maxilla or lateral wall of nasal cavity, and the soft tissue component is more, I would just reduce the turbinate soft tissue alone, not the bony part of the turbinate.
What about Vikas?
So see, piriform aperture increase is selectively done only for patients with gross, abnormality, which is visualized. Most of the work will be done on the turbinates. And as you rightly said, a CT scan is a must before you touch the turbinates, because nasal endoscopy will not tell us the details. So if I see the bone inside the turbinates to be large, I'll definitely remove the bone. And as in this case, you are showing that the mucosa on the, say, the roomy side is pretty large. So that obviously that mucosa is to be shrunk with a coblator or radio frequency, or even, cautery, whatever you want to use. You can see the mucosa on the lower part is very, very large. That is the part, the lower part and the posterior part, that mucosa actually has got a lot of mucus glands. So
yeah,
that
and I need to give it to you guys. I've just taken a slice. It would be always better to see the entire scan, but I just wanted to bring out that particular point as to how you would think.
So the medial part of the mucosa is going to be saved for all the patients, but the lower part of the mucosa and the lateral mucosa, if it is so thick and full of mucus glands, has to be resected. The bony part always goes away. So this gives you a functional nose, which will never give you a blockage again. And even if you, on this CT scan, if you do not see the hypertrophy on the side, which is narrow, I'll still remove the bony part on that side, because later on, 5 years down the line, this part is again going to become hypertrophied. So I'll do it on both the sides, irrespective of the deviation.
Anybody else who would like to give a difference of opinion to what Dr. Vikas has already said, or you concur?
Yeah, Saga here. So previously, we started using only the coblation or submucosal diathermy or RF only. But what we found was there was recurrences. As Vikas said, this definitely needs turbinoplasty, inferior turbinoplasty, wherein you are also removing part of the mucosal glands along with that, so that it actually addresses your allergic rhinitis as well as it helps in the opening of the airways. So ideal thing I would agree with Vikas is to go ahead with inferior turbinoplasty rather than just application or just doing the submucosal resection of the bone. Even though in the CT you may find there is bony hypertrophy, we may tend to do only removal of that particular bone, but eventually that soft tissue also hypertrophies. So it is always better to do a turbinoplasty rather than just doing either a SMDC or only the coblation.
Dr. Jimenen, what's your take on this? What subset of patients would you select each one modality?
First of all, I'd like to tell you, at this slice that you're showing here is what I call as the second zone of respiration. I will say that the middle meatal area or the middle turbinate area is where I would be focusing this area on. Second thing is, when you look at this turbinate, I'll ask myself, is this nasal cycle? So in 1 hour's time, if this scan was repeated, would we see that hypertrophy more on the left side than on the right side? So again, you have to understand, when we do these CT scans, right, this is just a picture in time.
Snapshot in time, yeah.
How this influences from it in a functional way, that we have to decide clinically. So when I look at this now, when I want to correct this, I would look at more anteriorly around the internal valve area where the real obstruction is.
That's exactly where I wanted to bring out.
Yeah, so the inferior turbinate, at that point, I will decide. Whereas for me, this may be normal.
Right.
The middle turbinate, if you see, is paradoxically bent. He's got a little bit of...
Jimenen, I just have to... Vijay, how are we doing with time?
I may say 8 o'clock, but still we can go ahead for another 15 minutes, maybe.
Okay, great. So that's all I need.
Yes, we have almost 500, more than 500 viewers live now.
Wow.
That's a lot.
Wow.
Okay. So coming back to the discussion, that whole point, right?
Yeah.
So I've described the functional nasal airway surgery, and that was when I was purely looking at the nose. But now, when we look at OSA per se, and we know that it's a bigger picture, I do nasal surgery as a structural repair to facilitate rehabilitation.
Right.
So it goes hand in hand with some form of skeletal work as well.
So I would now jump to the next question. So when you have OSA and allergic rhinitis, what would you rather correct? The turbinate or the septum? Obviously, we would like to correct both of them. But if you dig deeper, it's been said that correcting the septum does not experience the extent of dynamic changes as the turbinate tissue. And we know that it is the dynamic changes that influence the severity of obstructive sleep apnea and not the septum. So the septum is a static obstruction. Body is learned to deal with it. So one should bear in mind that the patient satisfaction after septoplasty may not be substantial in allergic rhinitis patients as in other non-allergic counterparts. I would like each one of you to comment on this. Dr. Seema.
So Srinivas, here the question here would be not septum plus turbinate. I would say
Correct.
Turbinate plus septum or not, because turbinate by default has to be addressed.
Correct. Would you want to touch the septum, or would you not want to touch a septum in a patient with allergic rhinitis and OSA?
Absolutely. So I'm coming to that. My decision to touch the septum would depend solely on the CT scan, because the allergic rhinitis treatment would have been done. And if I find that there is a significant deviation which is causing the obstruction, mind you, the counseling has to be intense, because obviously when you do a septoplasty, there will be a surgical benefit, but this benefit may not translate to the patient benefit unless the patient has been counseled well.
Exactly the point.
None of us are actually going to, touch the septum if it's not going to help. So when you know that the septum is going to be helped, this patient is going to be helped, I will do the septum, but intense counseling in terms of septal surgery is a result.
Because patients nowadays are very, very Google literate, and I think they want a lot of answers and a lot of counseling in that particular direction.
But turbinate to me is a no-brainer. Let me tell you that. I didn't mention that when everybody was trying.
No, I think that point is taken. The discussion is, the crux of the matter is septum plus, septum minus. If so, yes, why?
So Kishore, I would always deal with the septum if I see that it is even a little bit tilted, because anyway I'm operating on the nose. So why not do septoplasty? Because the patient, what is the bottom line of surgery? The patient would want a guarantee that the nose will remain open for life with or without a spray. So I work
on the backdrop of allergic rhinitis is what we're discussing.
Yes, on the backdrop of allergic rhinitis, I'll like to do maximum improvement which I can do on table, and with the spray, the patient should not have a problem later in life. So the nose has to always remain open. The post-nasal drip has to go away because we'll remove the mucosal glands from the inferior turbinate. The serous glands will be preserved so that there'll be no crusting, and the spray will be prescribed for life. So that is the bottom line for me. The patient has to be a happy patient for life once we touch the patient. Whether we do only turbinate or only septum does not matter in patient's life.
What do you think, Sagar? Anything else you want to add, Sandeep, Vijay?
Yeah, Srinivas, as when we learn, I think we all would have learned that by doing a septal surgery, your allergy is not going to improve. That's what our teachers have taught. But when in practice, we definitely would see patients with gross septal deviation and with allergy. But these patients definitely show signs of improvement post-operatively when you question them about the allergic rhinitis after the surgery. So yes, with the practice that we follow, these patients do benefit with your septal surgery along with your turbinate prostate surgeries.
Right.
I know that Dr. Jimenen is going to say the contradictory
No, I
words,
think we will.
But this is our practice. I am only saying what we practice.
No, that's the whole idea of the panel, so that we can extract as much as practical points from you guys, so that we can give some solid take-home points that would help them in practice. So here's another paper.
I'll just comment. Okay, you also have to understand that there is a huge spectrum of how people do septal surgery. The most
that also matters, yeah.
And we have always been taught that septal surgery is a headlight surgery, and doing septal surgery with headlight and endoscope is day and night.
Yeah,
well, that's again a Pandora's box. That's a huge thing.
Yeah.
Nobody would do a headlight surgery anymore. It's always
because you'll be very, very surprised. In Malaysia, at least, I know people who are still doing with headlights.
Fine. Then I'm not talking of that subset. I'm talking of endoscopic surgeons.
Because the problem is, when we have the endoscope, we also realize that we tend to go higher, addressing the septal deflections, which are
unless you take care of the high septum, there's absolutely no point doing a septal surgery, because the airflow is high up in the nose, along the middle turbinate. It's not along the floor of the nose.
Guys, I think we have little more to discuss and very short time. So I'll just quickly jump into the surgical management, and we'll directly talk about turbinates and what is the evidence out there. So this is a paper published by Pete Batra, which actually in adults with nasal airway obstruction from documented inferior turbinate hypertrophy, what they wanted to answer was, does nasal turbinate surgery alone improve disease-specific quality of life measures, symptoms, and or objective parameters with a minimum of 6 months follow-up? That was the question that they wanted to answer. And they reviewed 514 abstracts. 96 met the inclusion criteria, and 93 amongst them reported positive results with a subjective symptom improvement of more than 50%. So that's the evidence out there is overwhelming that inferior turbinate hypertrophy management as a surgical management, as an answer to OSA with allergic rhinitis, is here to stay.
So, Kishore, I wanted to add that our teachers used to say, don't ever touch the inferior turbinates. That is a paradigm shift.
Totally. So, quickly talking about the anatomy, I would like to talk a little more about this, but unfortunately, we don't have the time for that. So we'll just quickly shim. Are you guys aware of the turbinate pump? The concept of turbinate pump? This is actually something that's come out of Mass Eye and Ear Infirmary by Ralph Metzen, who actually says that you don't have to give an injection behind. All you have to do is give an injection at this point, just distal to the anterior end of the inferior turbinate, where all the branches of the branches coming from the anterior ethmoidal artery and also branches coming from the sphenopalatine and the facial sort of come onto the inferior turbinate. And just by giving an injection in that area, within 2 minutes, the entire mucosa just shrinks. And this is called the turbinate pump. And this is something that we can actually even practice in outpatient, and you can get good results for it. So let's quickly jump into surgical techniques. Here is a diagram running from A to F with the different surgical techniques, right from turbinectomies to simple lateralizations. And I'll quickly ask each one of you what techniques you would use. Okay, does just outfracture of inferior turbinate, would that work? Would that not work? Dr. Seema, just one short answer.
Yes, it would work.
Okay.
Not only that.
Okay. So it works, but it is not the only one that works. Okay, done. So would you just do a turbinate lateralization in your patients and let go?
No, I would always, by default, always use a radio frequency also.
Perfect. So the next question is again, radio frequency reduction in inferior turbinate and allergic rhinitis and non-allergic rhinitis. I think there is again a lot of robust data out there to show radio frequency ablation. And again, a lot of data again suggesting radio frequency. I just want to quickly ask you, how many of you use these radio frequency techniques on patients with soft tissue? Would you all use any of these techniques, or you might as well just prefer something more robust like a microdebrider, even with patients with soft tissue hypertrophy?
So I use microdebrider very, very often.
Whether it is a bony hypertrophy or a soft tissue hypertrophy?
Yes, so bone is removed obviously with the standard instruments. So I lift the flap and then remove the bone. But if it is a soft tissue hypertrophy, then as I said, I divide the inferior turbinate into 6 parts. Anterior 1/3, middle 1/3, and posterior 1/3, and upper half, lower half, upper half, lower half, upper half, lower half. The whole lower half is removed with the microdebrider because that contains more of the mucus glands. Whole upper half is preserved. So that part, the anterior part of that is taken care of with the radio frequency or coblation.
So you use a hybrid technique?
I use a hybrid technique always.
Jimenen.
Yep.
What do you do?
I use radio frequency plus lateralization.
Okay. Anybody using turbinator? I have no experience too much with it, and I would really welcome if any one of you have experience with this turbinator.
So I have tried in 4 to 5 cases. It was not great because it does not, animation is much easier. The surgery is not
exactly. I'm being honest, I have no experience with it somehow in my hands.
I concur with the same, just did it for the sake of trying it out. But by default, I'm not elaborating, answering you specifically. I stick to the turbinate with the radio frequency, period.
Fair enough.
I did a few times as well, Srinivas. It's too aggressive.
Right. So, anybody doing partial turbinectomies or medial flap inferior turbinectomies? Sagar?
Yeah, I do the turbinoplasty, yes.
Do you do this kind of a turbinoplasty wherein you do a medial flap?
Yeah. Kind of like a medial flap, yes. Yeah, almost the similar. We remove it with the debrider, and then remove the bone, and then rotate it and keep a surgical and apply either coblation or radio frequency to the superior part.
So you also do a hybrid technique? Do you really see the need when you do such a procedure to really add in a little bit of...
Sometimes just below the middle turbinate and superior to the inferior turbinate, you find like bulk of the, exactly, almost even superior to that. I do find just here, you notice that just below the pledget, you can notice that there is hypertrophied mucosa.
Right.
So for that, we need to address it with one of the tools.
Fine. Anybody doing this kind of a partial turbinectomy? Wherein...
Me. Almost always.
Right. So mucosal preservation technique, wherein you make an incision, create a flap.
Used to do it, but not anymore.
Yeah, so I think that's a fantastic point, Sagar, because it really doesn't matter. Because with all that, even if you do that, the end result basically sort of remains the same. And all this is of no value at the end of the day.
Lateral mucosa you should sacrifice. The medial mucosa you should preserve. Isn't
so
it?
At the end, so this is a technique where you preserve both of them. You just take out the mucosa and sort of leave it at the end to sort of stick. Don't put anything there.
So your last statement, Srinivas, is what I would really like to emphasize on. So I've done probably doing all of this for the FOMO, fear of missing out on not doing all of this. But at the end of the day, what matters is what you do at the end.
Perfect. So this is something that I've started doing nowadays, and I would like to take your inputs on that as well. If you see a very narrow piriform aperture, doing a piriform kind of a turbinoplasty, anyone having experience with this? Okay, so a quick comparison between techniques. Radiofrequency versus microdebrider. So here, comparing radiofrequency ablation with microdebrider inferior turbinate reduction, found that both techniques are effective, but no significant difference in terms of outcome based on technique. But the only thing that would matter is that the results for radiofrequency alone have sustained for about 3 to 6 months. This is again another paper, long-term outcomes in medial flap inferior turbinoplasty were superior to submucosal electrocautery or submucosal powered debrider reduction. Managing turbinate hypertrophy, again, coblation versus radiofrequency. Radiofrequency and coblation were both equally effective, but their effectiveness diminished by 3 years, which is a good time, so that they can come back to us and get another round of radiofrequency. Because it's a minimally invasive, we're not doing much to them. And I think the 3 years is a good enough. Do you guys concur?
I would generally like to do a permanent job.
Fair enough, Vikas.
Srinivas, I think, comparing two different techniques is possible only if you're doing a randomized controlled study, Otherwise, what was the inclusion criteria? What parameters did they take? And they are done by different authors. So it's
yes, some of them are actually good studies, Sandeep. I will share the original articles with you, but I think they're reasonably.
That's fine. What I mean to say is that I think still, apart from, there might be some superiority over one over the other. It might not be statistically significant. Ultimately, it is the surgeon doing the surgery. I think he should stick to whatever he's comfortable with and try to improve upon his own methods rather than just what Seema was saying.
Absolutely, point taken. My idea is to just show what is the evidence out there to sort of compare between the techniques. One should always do what what works best in their hands.
Yes.
So, of course, laser versus radiofrequency versus inferior turbinectomy, I think that's a no-brainer. So, when we talk about inferior turbinate surgery in OSA patients, I would like to quickly bring about that topic that there are two things that we are really scared of, which is bleeding in the postoperative period. And so would you really, what precautions would you all take while you do inferior turbinate surgery in patients with OSA? Quickly, one word answer from each one of you, please. Because you obviously can't do a regular packing in these patients. These are OSA patients. Either you have done it individually or a part of multi-level surgery. So what precautions would you all take to prevent this particular calamity?
Let me answer that in very simple ways. That when I'm doing radio frequency submucous insertions, no precautions needed, leave it open right there. I don't expect bleeding over there.
Correct. Done.
Because when you do the hybrid thing, when you use the microdebrider, the blood supply of the inferior turbinate is at the back, approximately 1 centimeter from the posterior end.
Correct.
So you do not cut over the bone in that part. If you remove the bone in that part, you'll get the bleeder. If you have removed the bone, then you make sure that you are leaving sufficient amount of soft tissue and coagulate that with the suction cautery or radio frequency, whatever, then you'll not get the bleeding.
Jimenen?
And same with, so hardly see any problems with bleeding.
Right. Sandeep, Vijay, Sagar, one word answers, please.
Nicely, as Vikas said, nicely cauterize the bleeding point intraoperatively so that you don't get into that.
So Mike, obvious, since all of you are saying the same thing, packing or no packing? I think that's something that we need to really put it across.
No packing.
If it's isolated turbinate work, no packing. If it's in association with other things, depending on what you've touched behind.
Correct.
Can
So
pack the nose with the nasopharyngeal airway.
Okay, that's it.
Just a point I make.
Yes, Jay.
The airway surgery that I do in the nose, and sometimes you can expect some bleeding. I cover these patients with tranexamic acid.
Right.
I put tranexamic during induction and for 1 or 2 days after surgery, and it helps.
Right, it does. It does. Sagar, anything else that you want to add here, or you?
Yeah, I had 2 patients who did not have any bleeding intra-op or immediate post-op. Actually, they had bleeding after 1 week.
Yes, it can happen.
Yeah, the scab fell off and that started to bleed and had to be.
It's not a very pleasant situation.
Exactly.
So how you can prevent that? If you're in that vessel area, then coagulate at 2 points, not only at the tip, coagulate also along the length.
Little bit
laterally. Then this problem will not happen.
So making sure of adequate hemostasis, number 1. 2, cover your patients with tranexamic acid a couple of days into the postoperative management. And 3, be as conservative as possible, especially along the blood supply of the inferior turbinate. Any one of you have come across empty nose syndrome in your patients?
I have.
Yeah.
I have
so
a couple of patients. One patient is bad. In fact, what happened is I had to cauterize to control the bleeding. And that whole part of the turbinate actually fell off after 2 months. And then he complained of empty nose syndrome. So
it is a definite entity, but what one needs to also understand that empty nose syndrome is associated with high levels of comorbid depression and anxiety. So one needs to sort of understand that these patients, you do massive reductions. I mean, earlier, people were doing turbinectomies left, right, and center, but people really didn't have. So empty nose syndrome it's not a straightforward condition. So when you're managing such patients, you need to be very careful and wary of the fact that some of them may have comorbid depression and anxiety symptoms, which you also need to sort of consider. So
empty nose syndrome, can I add?
Yes, Vijay.
It's more problematic in patients without OSA, for which we have done fluctuating. But to my patient series of those who are having OSA, no one has actually complained about ENS, though there is a lot of space after removing the inferior turbinate.
So the recommendations are, it is recommended that the techniques for inferior turbinate reduction should involve less than 50% of turbinate reduction. And this should allow the preservation of sufficient mucosa and intranasal volume to retain innate function and normal airflow dynamics.
Kishore, just one line to add,
Yeah.
that the nerve supply of the inferior turbinate comes from the attachment. So it's
Correct.
along the upper part. If you preserve the whole upper part, ENS will never happen.
Right, right. So again, I would like to bring in another data. It shows that, so this is again a very fantastic paper, which says, does comorbid anxiety predict quality of life outcomes in patients with chronic sinusitis following endoscopic sinus surgery? And this is something that actually suddenly struck me. And anxiety occurs with a higher prevalence in patients with CRS and the presence of comorbid anxiety. So again, when we treat these patients, we need to keep that in mind. So take home message.
Just bring a point here.
Yeah.
In my experience, most of our CRS patients are all mouth breathers, and the bigger issue is tongue posture.
Right.
So tongue posture may be driving the anxiety.
Maybe, yeah, because again, depression and anxiety are a direct comorbid conditions of OSA.
So we
Again, the chicken and egg story.
really need to look at the autonomic nervous system dysfunction from tongue posture, which again relates to nasal function.
Yes.
So, Kishore, just one line to add over here also. If you have a patient with deviated septum, I ask 3 questions. Does he prefer to sleep on the affected side, like Jimenen said earlier? So a deviated septum person will like to sleep on that side. Does he have a morning, headache and anxiety more in the morning hours because his sleep is disturbed? And third, whether it is claustrophobic.
Right.
90% of these patients will have claustrophobia.
Right.
So these are the 3 questions I ask these patients.
So the take home, because we're running out of time.
Sure.
Yeah.
Before going to the take home message.
Yes, Vijay, I'm listening.
He's mute. Vijay, unmute.
Muted. He muted himself.
Vijay, please unmute.
Can you hear?
Yes, now I can.
Dr. Pradeep Kumar Saikia from Jorhat is asking how to manage empty nose syndrome.
Okay, so management of empty nose syndrome is again a different thing. You have grafts that can be done. There are hyaluronic acid that can be injected. There are lots of things. There are medialization procedures that are done, but it's not that simple, because one needs to also understand that there is a lot of psychosomatic issues that are associated with empty nose syndrome. So the take-home points are: 1 or more pathologic sinonasal conditions are present in 70% of OSA patients. Nasal obstruction may play an important role in the pathophysiology of hypoxemia in OSA patients, especially in patients with moderate to severe OSA. Detection and treatment of rhinitis in patients with OSA could improve the effectiveness and adherence of CPAP and outcomes in multi-level surgery in patients with OSA. So I would like to end with this statement. As Vikas said earlier, nose is both pivotal and primary in the treatment of OSA. Thank you very much. Thank you all the panelists for a fantastic contribution for this particular panel. Thank you, Indian Academy of Otolaryngology, Head and Neck Surgery. Let me stop.
Thank you, all the viewers, especially Dr. Srinivas Kishore, excellent moderation. And I would like to thank Jivenen for immediately accepting our proposal for this program. And thank you very much. And all the panelists, thank you very much for your contribution. And also I would like to thank GSK for this webinar series, which is being organized once in a month. For the next 7 months, we are going to have this program on every Sunday evening, 6 to 8 p.m. Thank you, one and all. Thank you.
Thank you very much.
Thank you, Jivenen, for it's 12 o'clock for you. Very late.
Take care, everyone. Wonderful discussion. Take care.
Thank you.
Thank you all.
Thank you.
Thanks.
Wonderful moderation.
Thank you, Dr. Gautam.
Very nice.
Yes, thanks, Dr.
Very,
Gautam.
very good. Very, very nice discussions. Very nice.
Thank you, sir. Thank you.
Thank you. I'm sure